Well, that's a great question. FLT3 inhibitors for the development and treatment of AML patients with FLT3 mutant disease really has been a field that I've been involved in for several years, tempered by a lot of frustrations with sort of the early compounds. Now we're in the era where we can actually, just like in CML, we can start to have the option to choose and think about different inhibitors in this setting. Slimmers CML, where we have a number of BCR-ABL inhibitors that are FDA approved and have different side effect profiles. We now have a number of FLT3 developments, FLT3 inhibitors in clinical development. Obviously, midostaurin, a first generation FLT3 inhibitor, was presented in a plenary session in 2015, demonstrating that it improved the outcome of standard chemotherapy for younger AML patients with FLT3 disease. However, many people have said exactly what you said. Midostaurin actually, as compared to the second and third and newer generation tyrosine kinase inhibitors, is a relatively weak FLT3 inhibitor. It inhibits many other receptor tyrosine kinase pathways other than just FLT3. So a number of other candidates coming to the forefront, Daiichi Sankyo with their quizartinib, Astellas with gilteritinib, AROG Pharmaceuticals with crenolinib, and a number of even earlier compounds, really kind of getting into these patients and demonstrating that they do result in higher response rates. But we yet, as of now, don't know how important the specificity of the tyrosine kinase inhibitor needs to be. Is a more potent but highly selective FLT3 inhibitor going to be better when added to standard chemotherapy for these patients? Or is it more important, given the clonal heterogeneity and the clonal evolution of AML in many patients, to have a more broader tyrosine kinase inhibitor that is going to block FLT3 negative AML cells that occur concurrently in the same patient with FLT3 mutant AML? And I think that the question is still out there. I think that we're eagerly awaiting clinical trials which are going to be looking at the efficacy of one tyrosine kinase inhibitor versus another tyrosine kinase inhibitor added to chemotherapy for the treatment of these patients. And I think that's really going to answer your disease, but that's been a recurring theme. Do we want the most potent, most specific inhibitor and then have disease grow out that's FLT3 negative? Or do we want to have a broader spectrum inhibitor that also may have more toxicities, right? More myelosuppression, more gastrointestinal toxicities, may not be inefficacious because we may not be able to give it at an efficacious dose. So those are great questions, and I think that we are fortunately moving into the era where I think in this last year or two, people have really started to pull out the FLT3 mutant patients and say, this is a population where we've really started to validate tyrosine kinase inhibition for this particular subset.